Good morning, everyone, and thank you, Enes, for the introduction, and definitely thank you to Hugo for inviting me to be here. This is my first time, and I'm very impressed by the conference and the organization of the conference and the speakers as well. Very interesting topic yesterday about the cellular and musculoskeletal adaptation in relation to disuse in other exercise or other intervention. So my name is Ashraf Gorgey. I'm a professor at Virginia Commonwealth University. And today I want to share with you some of our work about neuromuscular electrical stimulation and how we progress from stimulating innervated muscle to stimulation of the innervated muscle. So early in 2010, we are very fascinated about restoring muscle in persons with chronic spinal cord injury, meaning people who have been injured for 1 year, and mostly those who are chronic Asia A and Asia B. This is type of classification that we use with a spinal cord injury, which means you don't have any volitional movement below the level of injury. And we are primarily excited about using neuromuscular electrical stimulation here. You can see the electrodes are placed on the vastus medialis, and the top electrodes are placed on vastus lateralis, and they are hooked up to the stimulation where people can move their leg with using ankle weights. We are loading the muscles using ankle weights and primarily the knee extensors. And our initial trial was published in 2012 when we did magnetic resonance imaging, and we have two groups of a spinal cord injury. The first group get 12 weeks of resistance training and diet, and the other group just get diet, and they didn't receive any resistance exercise. And we included heterogeneous group because they was very difficult in a spinal cord injury to recruit homogeneous group, and we we measure muscle size by magnetic resonance imaging, something that I've been doing almost for 15 years and I enjoy doing, because unlike other groups, we are not only measuring muscle size, but we are measuring something called intramuscular fat, which is the fat infiltrated inside the muscle. Account for all these fats that's infiltrated inside the muscle. We also measuring something called bone marrow fat, but I'm not presenting anything on it as well today. So our initial results in 2012 showed that when we used 12 weeks of resistance training, this is the muscle slices of MRI. Starting here is the hip joint, and over here is the knee joint. We found that the muscle size has increased by almost 35% after using neuromuscular electrical stimulation in conjunction with diet. On the other side, we found that the intramuscular fat, or what we call it the bad fat, or the fat that has some metabolic inactivity on some of the cellular mechanism on the muscle cells, has also showed decrease. And this is the mean of the entire group. So we have expanded our work, and we did another study where we combined resistance training, but this type was androgen or testosterone for 16 weeks. So we went in and recruited 20 individuals, and this time we were successful to have homogeneous group, randomized clinical trial where we have 10 subjects per group. One group received resistance training and testosterone. The other group received testosterone only. And this are the weeks of training, 16 weeks. And this is showing you that the group that did resistance training, how much weight they were able to lift. This is in US 20 pounds, which is equivalent in the European like to 10.5, 10.6 kilogram. of weights on their legs. So a paralyzed individual, completely paralyzed, can lift up to 10.6. You can go home and try to lift on your biceps 10.6 kilogram and see how heavy is this. So you can recognize person who have been chronic injured for years lifting this much weight. And the findings showed that the group that did the resistance training with testosterone, regardless the way we use, and I want you to look over here, this is how much adaptation that we get in their muscle size. This is in absolute absolute centimeter square. We have showed increase in muscle size by 20 centimeter, almost 20 centimeter on both the right or left leg. So we were able to show that we were able with resistance training and testosterone to evoke muscle hypertrophy, or the muscles gets bigger. This has led us to, and this is actually published in Journal of Applied Physiology, where we went in and did histochemistry and looked at the adaptation, fiber cross-section area. Other groups have done this as well. But this time we looked at mitochondrial adaptation, and we showed that with fiber hypertrophy, there is increase in citrate synthase and succinate dehydrogenase complex 2 after 16 weeks of resistance. So you can see here the fiber. I mean, you don't need to have a results. You can see here is the fiber. Look how big is the fiber after training. So we are excited about this, but to our surprise, that's this is the scheme of the study when we started the study. You can see here is we have reached out to 450, 155, and I'm just want to go through this quickly. 105 expressed interest. We screened about 115, and 40 were qualified. 26 were enrolled in the trial that I just presented to you. 4 withdrew. 22 completed the study, and we presented on 20. But during the screening, we found that there are 8 persons did not respond to electrical stimulation. And this is where get me excited, whereas Enes is here, where I'm here today. That we tried every possible way. This is electrical stimulation where the phase duration doesn't exceed 450 microsecond, and we tried every possible way, and the muscles is not responsive. And I was very unhappy because I want to enroll them in our trial, but their muscles are not responsive. So we ended up excluding. During this 4-year period while I was doing the trial, what was possible to do for this individual that's we can let them exercise. And of course, Enes presented this, and Kim presented this, and Professor Meyer presented this. So I'm not going to show. So those people have a coda equina lesion, and I echo what Enes said. We need to have a classification for these people because they have a variety of lesions. They could be peripheral nerves, they could be partial denervation, they could be, there is a mix of group that we as researcher clinicians, we really don't know how to classify them, and everybody dealing with them as one combination and put them in one basket, which I don't think it is right. So I'm just going for the sake, but this is what's really fascinating, that we were able to capture MRI on one of them, and this is the MRI of a paralyzed, innervated individual, and this is the MRI of the legs of the innervated individual. I really don't need to say anything. You can look at the image and you can see the difference. Completely fibrous tissue, muscles are completely gone, nothing but nothing but fat, and even you can see that the bone quality has been deteriorated. I have a master student in my lab, Sabu. She gets excited about this, and she started to put some numbers based on the analysis of the MRI, and this is only based on one matched subject. And you can see here, again, this is the hip joint, this is the knee joint, this is the whole thigh muscle cross-section area. You can see how big is the muscle cross-section area in the innervated. This is the innervated. This is the knee extensor. You can see almost the knee extensor are gone, 5 centimeters square only of muscle tissue. And you don't need my explanation. This is how much fat in person was denervated compared to almost everything has gone in their muscles, no muscle tissue, almost everything is fat and fibrous tissue. We just recently published a paper in the Journal of Spinal Cord showing that that's when we did 8 individuals with innervated match with 8 people with denervated, completely matched based on age, body weight, and as much as Asia classification. Again, this is the MRI of the innervated individual. This is the MRI of the innervated. And basically, we're trying in the form of a group average to compare this and expand our work to include not only muscle, but to include bone. We found that's very similar to our earlier findings. This is the whole psi of innervated individuals. This is the whole psi muscle cross-section area, and same thing for knee extensor, whether right or left. So there is almost, you can see almost close to 50% reduction in muscle cross-section area following the innervated individual, whether you look for whole psi or knee extensor cross-section. So it is big deal when we expanded our work to include the bone mineral density, and you can see this is the distal femur bone mineral density and the proximal tibia. And why is this region specifically? Because these regions are more likely for persons with spinal cord injury to experience fracture, and we found that definitely they are impacted heavily. Another findings of the paper that we found that with aging or with time since injury, that the denervated group tends to show a reduction in their knee bone mineral density, which is not only muscle quality is impacted, but bone mineral density, and this is something that we have to pay attention if we don't intervene. So what did we do? So this is our protocol, and I think this is where why I'm here today is just we started to think about combining long pulse width stimulation, and I'll give credits to the folks sitting here, because in United States, North America, there was a big challenge about bringing this technology because it is not FDA, and in North America, they wouldn't let us use this stimulator because of the fear of the other problem that Enes and all my colleagues mentioned. So we said that we are going to get IRB approval to do testosterone combined with long pulse width stimulation with the hope to enhance the anabolic environment in this population. And again, this is the then 2X, and this is the type of stimulator. So I'm just going to same type of stimulator that we were able to bring 2 units into United States. And this is an earlier findings from the Rice group that showed that here is the muscles early on when they start training and they continue training up to 2 years. So you can see the difference here in the knee extensors compared to this fibrotic muscle tissue, which is very impressive results, and I'm very excited. And I want to replicate this with testosterone in United States. So we start to do this study here. Here is the design of the study, the screening and consenting randomization. One group will get the testosterone plus long pulse width stimulation. They will do 2 visits a week, and another group will just do the testosterone plus sham electrical stimulation, which is a controlled electrical stimulation, and they will go for 12 months of training, and they do 6 months of assessment. And here is one of the things that's an area that requires huge research, which is the stimulation parameter. That's it is very vague because when we started the stimulation, that was the recommendation based on the Rice protocol to start 120, 150, interpulse interval 400, and so on, and reach down all over. And that's what's the proposed. But what we found that here's one patient that's when we applied this, we started here at 200 millisecond. That's week 1, I should say. That's week 1, 200 millisecond, not in order to get any twitches, and with 400 millisecond, and this much frequency, no weights. And we have This is the stimulation amplitude. You can see the stimulation amplitude is really high. We're going to do 4 sets of 10, and you can see with 4 sets of 10, people towards the end, they get to close to 200, which is the maximum that stimulation can give, or 195. But the surprising is that in week 45, this 200 millisecond dropped to 35 millisecond, same phase, and the frequency went from 1.6 hertz to 25 hertz, and now the individual can carry ankle weights, which was impressive. And I'll show you the videos, because if I didn't show you the videos, you wouldn't believe me. And the stimulation amplitude here, oops, oh, I'm bad. I don't want to do this. I want to go back. And the stimulation amplitude almost went down by 19%. So when you do the average, so the people need less current amplitude. So the bottom line that this is require more research and more interest on how we can stimulate the innervated muscles properly. So this is the video. This is the patient, our patient in, how can you run the video? How can you just click? Oh, this is the patient. Oh, thank you, I got it. So this is the patient in August 2018. And you can see just mild twitches. And I'm just happy to see the twitches, because we tried the other stimulator, nothing. And I'm just moving his legs with the hope that one day he will be doing this. But he cannot move his leg. But on June of 2019, which is, you can do the math, 4, 6, 10 months later, when we turn on the stimulator and we keep, you can see the patient now is moving his leg into extension, which is quite impressive to see that the patient who couldn't move his legs, and this is the DEN 2X, and just really to show you this is the type of stimulator that we have been using. On the other hand, we are using the control group. We're using a home-based approach, where we give them a commercial unit, and via telehealth, secure telehealth, we send them home, and we can train them from home, and we can train them from home as much as we do. This is the control group that get testosterone only, and just the commercial or sham electrical stimulation. So today, over the 4 year, we recruited 12 patients in just one center, and just to let you know, it wasn't really easy to enroll 12 patients and keep them for 1 year into the study. 2 withdrew and 10 finished, and we are now close the study for recruitment, and we are analyzing our data, and I'm just going to show you some of our data here with the MRI. Again, this is ID1, so if you wanna make sure that we are analyzing our MRI right, magnetic resonance imaging, you can see here is just the reliability. For the whole thigh muscle cross-section, they are just mirroring each other, and this is 6 months. We don't have the 1 year yet, so this is 6 months. Same thing for subject 10, almost exactly identical, so no change in the whole thigh. But when you look at the knee extensor where we train, you can see an increase in muscle cross-section area. This is the baseline, 6 months, and very similar to Professor Ken mentioned that if you want to take a look at the muscle, don't be rushing, give it its time. Same thing here with the knee extensor with subject ID10, there is some improvement. So we have some strengths and limitation to our study that I want to share with you importantly. First thing, it is safe, like if I'm talking in a North America conference, it is safe to say that long pulse width stimulation can be applied considering the indication in the electrodes and the gel and the spongy tissue. We don't think that twice a week is enough to restore muscle size in person with a spinal cord injury or with denervation. We need more time and more frequency, and we think that home-based approach may be the time to take it to the next step. And by this, I conclude my talk. Thank you.
Thank you very much, Ashraf. It's a very wonderful presentation. And I congratulate you that you are Boss, you are able to continue the work of Hugo Carraro, Jonathan Chavez, Winfried Meyer, as we started in the RISE project 20 years ago. So I think it's very important to continue this work and to bring new knowledge and new stimulations to this.